Good to be with you. I feel highly uncredentialed among this group of doctors and other intelligent people, but we have been working in our office, as others, John Conyers and others in Congress have been, on prevention science, the application of real-world, rigorous science and evaluation to our public policy challenges. Sort of amazed me. I came into office in 2011, and one of the first things that I tried to do, especially as I was entering the Ways and Means Committee roughly 2 years ago, was I tried to divine what was guiding our largest programs of government, particularly our social programs. How had they been developed? What evidence was there to indicate that the particular models that were adopted were going to work? What evidence after the fact has there been demonstrating the level of effectiveness or lack thereof for some of these programs that benefit millions of Americans, but perhaps suboptimally? What's been the evidence base for our pilot programs over the years that we've launched out of Washington, D.C.? Oftentimes non-existent. Blew my mind. There have been pilot programs funded by federal taxpayers with no evaluative component whatsoever. Where there is an evaluation, oftentimes it's inscrutable to policymakers and their staffers alike, or it's difficult to find. They're not located in one central place. So these are easy fixes. If we change our mindset to one of prevention, to one of basing our policies on science, on facts, and I think we have a real opportune moment working with stakeholders like yourself and advocates and concerned citizens during a time of scarce resources to ensure that every federal tax dollar that's spent is spent on things that have been rigorously evaluated or piloted beforehand or are already working in communities or states around the country. And all of us can cite not-for-profits and religiously affiliated organizations or just dynamic individuals. They're doing fantastic evidence-based things that just need to be scaled up. So that brings me to my deepest involvement in so far at least, in this area of prevention science and evidence-based policymaking. And it's a bill that I drafted working with John Delaney of Maryland. I happen to be a Republican, he happens to be a Democrat. And we think that science ought not, it ought to transcend partisan bounds. So the social impact bond model, if you're not familiar with it, it was developed in the United Kingdom. And the first projects have been funded in the UK. Initial results are positive. Effectively, government, in this case the Department of Treasury working with state and local governments, will identify evidence-based interventions that are already working on account of those not-for-profits or in some cases government efforts, where a very rigorous evidence base currently exists to demonstrate that the needle is being moved in a significant way on things like chronic homelessness or preventing foster children from aging out of the system or addressing asthma challenges experienced by low-income individuals, or preventing or at least reducing the number of the incidence of infant mortality, a big problem in my home state of Indiana. We know there are interventions to help address all of these things, and there's a body of evidence. So the challenge is just scaling up these interventions. Where's the money going to come from in order to keep us from having to spend more money later on? The old saying, an ounce of prevention is worth a pound of cure, is something that the social impact bond was designed to address. We deal with a 10-year budget window here in Washington, D.C. So oftentimes, we know if we were to scale up something directly by just spending taxpayer dollars on the scaling activity across different geographies and populations, we know in year 11 or year 15 or year 20, we would save federal dollars from a number of different programs. So in the case of say, the Nurse Family Partnership, a program that dispatches medical providers into low-income communities, works with expectant mothers on things like nutrition and taking the right health measures to ensure that that child is born in a healthy way, and then stays with the mother for the first 2 years of that child's life, we know that saves the federal government significant amounts of money on Medicaid dollars, to say nothing of the state and local savings that are also enjoyed. Well, we now have the ability, because of modern databases and the development of our evaluative systems, to aggregate the savings that will be realized by implementing a nurse-family partnership in, say, a municipality like Indianapolis. And we can figure out how much Medicaid savings will exist in years 7 or 8 by implementation of this program. Well, let's say it's $50 million, to choose an arbitrary sum. Well, if by implementing the nurse-family partnership, we're able to save something more than that $50 million, or something approaching that $50 million, then we might justify guaranteeing that if private investors want to take their own money to scale up the nurse-family partnership in Indianapolis, Indiana, they'll be paid back out of that pool of future government savings. So this is really not a bond per se. You've probably picked up on that. This is really a contract. And there would be an independent evaluator chosen by both the federal government working with the applicant, municipality, or state government. The independent evaluator would validate that certain positive health outcomes, and in the case of the nurse-family partnership, even educational outcomes are met. This is all science-based, it's all fact-based. If the intervention, if the scaling activity does not work, then the investors are either not paid back, or they're paid back some sum that is less than their investment to scale the intervention. So we're effectively creating, for the market-minded amongst us, you're picking up, this is like creating a market within the welfare space, within the space of public policy programs that serve our most at-risk Americans, low-income individuals, those with physical handicaps of one form or another. Then we publish all results from the final evaluation and certain intermediate evaluations on a public website. Because those who understand markets know that investors only make rational decisions if they're perfectly rational. No one's perfectly rational. Or perfectly informed. That's how a perfect market functions. So we're trying to replicate the sort of market environment here by ensuring that there's complete transparency about all optimal outcomes and suboptimal outcomes, so that future investors can learn from these things and improve upon implementation next time. This is how markets work. This is not how government typically works. The way government typically works is press releases are issued when there's anecdotal evidence suggesting that a certain program has succeeded. Politicians descend upon the facility that's providing those services, or get photo ops with some of the recipients. And when we have suboptimal outcomes, politicians sort of dust it under the rug, or oftentimes manipulate the numbers because it's politically inconvenient, it's uncomfortable to have put forward something, to spend taxpayer money on something that didn't really work. So we want to turn that on its head and advertise both the successes and failures, so that our not-for-profit leaders, academics, policymakers, and rank-and-file Americans will know for sure what is working. We build that evidence base, and I think the results could just be amazing. The ability to scale up, and based on that growing evidence-based, various social and public health interventions that we have access to in this country. So I think we have a really good opportunity to pass this legislation. The initial results from the United Kingdom are positive, based on their anti-recidivism initiative in Peterborough Prison. Here in the U.S., you should know, and many of you do, that many states and localities are already initiating their own social impact bond projects. But the advantage to having the federal government have its own legislation, its own social impact bond program, is that oftentimes the largest savings come come from the savings realized here at the federal level. Medicaid's probably the best example. Maybe SNAP is another good example. So to the extent more savings are realized, then that provides more positive ROI opportunities for investors that want to invest in one of these things. They want to get their money back so that they will scrutinize the implementation of these programs. And they want to get their money back, in most cases, based on my conversations with investors, not so that they can enrich themselves, but so that they can redeploy that capital to help more people. So this is really, I commend the British for developing this model. I'm glad that John Delaney worked with me to help adapt it here to the United States. I hope if you haven't heard about this, you'll contact our office, maybe to learn a little bit more about it, and encourage some of your legislators to be supportive. I'm hopeful that this is something next year that can become law. We've had very constructive conversations with folks on both sides of the aisle and at the highest levels of government. So I thank all of you for your work, and I'm sorry if I've gone on a bit long. Continue to invite me, though, please. Thank you.